Good evening, everyone. Today I'll be speaking about sepsis management guidelines. Uh, we'll just go through history. Surviving Sepsis campaign was initially launched in 2002 in Barcelona Declaration. Later on, 2004, sepsis bundles was introduced, which included a 6-hour management bundle and 24-hour management bundle. Later on, guidelines were revised, and in 2013, a 3-hour management bundle and 6-hour management bundle was introduced, and 2018 sepsis bundle include a 1-hour management bundle. We are very familiar with the term SIRS, sepsis, severe sepsis and septic shock, which had been studied earlier. Temperature more than 38 or less than 36, heart rate more than 90, or respiratory rate more than 20, a total count less than 4,000 or more than 12,000. A patient who met any of these two criteria fulfilled the definition of SIRS. And sepsis infection or any suspected infection leading to onset of SIRS. And severe sepsis was defined as sepsis complicated by any organ dysfunction. And septic shock was a sepsis induced hypotension persisting despite adequate fluid resuscitation. But recently, all these definitions have been changed. Right now, a sepsis definition is a life-threatening organ dysfunction caused by a dysregulated host response to infection. And to septic shock, it is considered as a subset with circulatory or cellular or metabolic abnormality when it is profound. Or in other words, sepsis with persisting hypertension requiring vasopressors to maintain a mean arterial BP of more than 65 or serum lactate more than 2 millimoles per liter despite adequate fluid resuscitation. Now, before going in detail regarding the sepsis bundle and all the protocols, we'll have a quick uh, overview about some of the tools which are being used. First is I have already explained about the SIRS criteria. Then we look for vital signs. We look for any signs of infection. One of the scores which are being used was QSOFA score, that is quick sequential organ failure assessment, which included a systolic BP less than 100 millimeter of mercury, respiratory rate more than 20 per minute, a Glasgow coma scale less than 14. Other scores which we should know about is National Early Warning Score, that is NEWS, which included respiratory rate, saturation SpO2, temperature, systolic BP, heart rate, as well as ABPU, that is alert, verbal, pain, unresponsive. And the other score which we should be knowing is a mu score, that is MEWS, that is modified early warranty score, that included respiratory rate, SpO2, temperature, systolic BP, heart rate, and ABPU. But as per the present recommendation, using QSOFA compared to SIRS or NEWS or MEWS score as single screening tool for sepsis or septic shock is no longer recommended. Coming to the guidelines, we have a 2021 Surviving Sepsis campaign bundle of care, 1-hour bundle, which include a initial resuscitation for sepsis and septic shock. It includes 5 points. First is we should measure the patient's lactate level, obtain a blood culture. Second point is obtain blood culture before giving antibiotics. Third point is administer broad spectrum antibiotics. Fourth is IV fluids at rate of 30 ml per kg, and vasopressors if hypotensive during or after fluid resuscitation to maintain a MAP more than 65. These 5 may not be complete. All the bundles may not be completed within the first hour. Now we are mainly, previously we were aiming for a early goal-directed therapy, which is now evolved to a usual care. Coming to each of the points, first is initial resuscitation. That is, a sepsis or septic shock is considered as a medical emergency. Treatment and resuscitation should be begun immediately. The fluids are given at the rate of 30 ml per kg. It should be given within the first 3 hours. Crystalloids are preferred. Starch and gelatin should be avoided. If there is large resuscitation with the crystalloids, albumin can be given. We should use a dynamic parameters like response to passive leg raise or fluid bolus, pulse pressure variability, stroke volume variability, and echo to assess the fluid, to guide the fluid resuscitation. Capillary refill time can also be used as an adjuvant to assess the fluid resuscitation. Resuscitation should be guided to decrease the lactate in patients with increased lactate. That is first point on the initial resuscitation. Second is regarding the vasopressors. Our target is to maintain a mean BP of more than 65 millimeters of mercury. In all the patients, it is advised to consider invasive BP monitoring. Noradrenaline is the drug of choice, the vasoconstrictor of first line of choice. If not adequate, if BP is not coming under control with noradrenaline, add vasopressin instead of escalating the dose of noradrenaline. And if not, as a third line, we can add epinephrine. For patients with a septic shock and cardiac dysfunction with persistent hypertension, despite of this volume resuscitation, we can add dobutamine in addition to the noradrenaline. Another point which is to be noted is we can start the vasopressors in the peripheral line. We need not wait for central line because we have to start as early as possible. Another drug which is recommended is levosimendan. That is a calcium sensitizing drug with inotropic and vasodilating property. Coming to the third point, that is the antibiotic. The adults with suspected sepsis or septic shock but unconfirmed infection, continuously reevaluation and searching for alternative diagnosis and discontinuing the empirical antimicrobials can be done if an alternative cause of illness is demonstrated. Administer all the antimicrobials immediately, ideally within 1 hour of recognition. If MRSA is suspected, we should start antimicrobials with MRSA coverage. If multi-drug resistant is suspected, 2 antimicrobials with gram-negative coverage is required. Antivirals is no longer recommended. Empirical antifungal is to be started if there is high risk of fungal infection. Optimize the dose of drugs and if there is prompt removal of IV access if any infection is suspected is recommended now. Coming to the ventilation strategy, adult with sepsis-induced hypoxemia, respiratory failure, use of HFNO or NIV is suggested. And in patients with the ARDS, low tidal volume strategy is recommended. Use upper limit goal of plateau pressure of 30 centimeter of water. And high PP is recommended. And in patients with ARDS, prone ventilation is recommended for 12 hours. And in case of muscle relaxants, a bolus of muscle relaxant is advised than a continuous infusion. And for sepsis-induced severe ARDS, veno-venous ECMO when conventional mechanical ventilation fails in experienced centers. Coming to the other recommendations, other than these basic things, IV corticosteroids can be given in patients on vasopressors. We should stick on the restrictive transfusion strategy. IV immunoglobulins are not at all recommended. Stress ulcer prophylaxis should be given. This one, thromboembolic prophylaxis, both mechanical as well as pharmacological, to be followed. And in patients, glucose level more than 180 milligram per deciliter, insulin therapy is to be initiated. And regarding nutrition, enteral nutrition is to be initiated within 72 hours if there is no contraindication. And as per this surviving sepsis campaign, sodium bicarbonate is suggested in patients with septic shock and severe metabolic acidosis and AKI. And to conclude with, we should discuss all these goals of care and progress and prognosis with the patient and families. So, thank you, sir.
Very good. The first and to the point, and what is the role of paracetamol in this? So, any recommendation to the paracetamol is that, let's say, supposing they strike a fever. Can normally reduce fever, but also does it have any other
Excuse me, sir.
Sir,
Your mic is not so clearly audible, sir. You can place it around your neck.
no,